Examination of the spine demonstrated midline point tenderness around the T12 L1 level. Neurological examination lower limbs was normal. Thoracolumbar spine X-ray anterior height, loss of T12 vertebra, otherwise normal. Okay. So there is anterior height loss of T12 vertebra. Here the problem is that there is now at this present day the T score is better, is out of the range of osteoporosis now. And Frank's 10-year probability of major osteoporotic fracture still is 27% for this man. What is the most appropriate management of the patient's osteoporosis? So anybody, you know the cutoff mark for the Frank's score because Dr. Haji is there, Dr. Saad. Dr. Haji, what is the cutoff mark for Frank's, 10-year probability of major osteoporotic fracture? Where we can stop the bisphosphonates in a patient with osteoporosis?
Usually after 5 years. But here is there is any fracture, new fracture or what?
So what do you think about the Frank's score? You remember something because the probability of major osteoporotic fracture is 27% on 10-year probability on Frank's. And for hip fracture, it is 8.7. So we need to stop the this bisphosphonate or continue?
According to the
Continue.
fracture here.
So continue. So fracture before many years.
No, right
before
now.
Before 5 years fracture, yeah.
No, right now I'm not asking. 5 years.
No fracture now.
The diagnosis. So why you want to continue 5 years and
5 years they took the medication for 5 years. So you want to stop?
valid, yes, for a typical fracture, unless there is
Okay, hold.
new fracture. Hold further.
No fracture.
Process. Repeat DEXA in 2 years. DEXA fracture.
Hold further osteoporosis treatment. Repeat DEXA scan in 2 years.
Fracture.
So what do you think? I have no idea about the Frank's score. How much?
Yeah, I'm not sure. I think.
Me too. Also not sure.
I think you give holiday if there is no new fracture.
Yeah, no new fracture. Okay. Let's scan. Okay, we will go with the first one or last one, Yani.
No, first the first one. Hold further. I think. Not sure, but I think. Let's see.
Okay, hold further osteoporosis. We will repeat DEXA scan in 2 years. Okay, because this one, I think if we will stop this treatment, this will go back, go up again. I think this.
Yes, but you have to, because there is a typical fracture if you continue treatment. Biphosphonate can cause a typical fracture.
Dr. Tariq, it's the T
If
score
there is high risk for fracture, you will continue.
There is no new fracture, only 5 years before.
Fracture score 27.
Yeah.
Hold and repeat after 2 years. Let's see.
Okay, let us see.
Yes. Oh, no.
Continue treatment because the T score is very near and Frank's probability. I don't know what is the cutoff. Let us see. Patient's bone mineral density has improved secondary to her treatment with hyaluronic acid. However, her recent back pain and abnormal thoracolumbar X-rays suggest she has suffered from osteoporotic vertebral fracture. So this is, I was saying no fracture, but there is,
She has a new fracture.
New fracture. Yeah, because they said here.
New fracture. You can stop.
Yeah.
With hold.
Spine demonstrated midline point tenderness around T12 L1. Neurological examination, and they said thoracolumbar X-ray, spine X-ray, anterior height loss of T12 vertebra. So this height loss is a fracture basically. Height loss, anterior height loss is a fracture basically. Yes. So you are right. So it is a recent fracture again.
We will continue.
Yeah. So the patient's bone mineral density has improved slightly to her treatment with hyaluronic acid. However, recent back pain and thoracolumbar, abnormal thoracolumbar X-ray suggest she has suffered from osteoporotic vertebral fracture. So loss of height is there, A recent back pain and abnormal thoracolumbar. She has suffered from osteoporotic vertebral fracture. In one study, continued hyaluronic acid from 5 to 10 years treatment reduced the incidence of clinical vertebral fractures in all patients regardless of T score. Therefore, continuing hyaluronic acid treatment would be recommended for this patient. So, regardless of the T score, though the T score is well below, is above, you can say, above minus 2.5, but regardless of T score, to control the fractures, we have to continue the treatment. And they are saying for 5 to 10 years. From 5 to 10 years treatment, reduce the incidence of clinical vertebral fractures. Due to the increased awareness of the potential complications, long-term bisphosphonate treatment breaks or drug holidays are now employed for some patients. Specifically, a treatment break should be considered for patients less than 75 years of age. With femoral neck T score more than minus 2.5 will be good enough. So the treatment break should be considered for patients less than 75 years of age. So more than 75 years, I think we will not give the treatment break. If moral neck T score more than minus 2.5, no history of osteoporotic fracture, and deemed low risk following assessment by the WHO fracture risk assessment tool, FRAX, and National Osteoporosis Guideline Group, NOG guidance. For such a patient, treatment would typically be suspended for 2 years with repeat DEXA scan at the end of that period or sooner in the event of fragility fracture. So this is what they are saying about the FRAX score. So no history of osteoporotic vertebral fracture. Like we have seen in our patient, there is osteoporotic vertebral fracture and deemed low risk following assessment with the WHO FRAX score and NOG guidance. If low risk, then you can stop. Okay. And if no history of osteoporotic vertebral fracture, we can stop. For such a patient, treatment would typically be suspended for 2 years with repeat DEXA scan at the end of that period or sooner in the event of fragility fracture. Okay, in the same scenario, if they don't give us the vertebral fracture, we can stop the treatment in our patient, okay? For a period of 2 years, and then the option A will be good enough, okay? And you can see 23% is there, and discontinued hyaluronic acid and initiate treatment with denosumab, 34%. Parenteral osteoporosis treatments such as zoledronic acid or denosumab should be considered patient is intolerant to oral bisphosphonates or in the event of treatment failure defined as 2 or more fractures on treatment or 1 fracture and a fall in bone mineral density. Okay. So bisphosphonates beyond 5 years. So this is from the BMJ. Okay. So we have read on in detail the guidelines related to osteoporosis management, and if there will be any question related to that, then we will refer to that, to these notes again. Otherwise, no need. What is the most likely diagnosis? Jacob's arthropathy, rheumatoid arthritis, gout, and okay. Dr. Saad, do you have my number? Dr. Saad,
Yes,
if you
Dr.
can,
Tariq. Yes, yes,
you
I
have
do
my
have.
number?
Yes, yes, I do have.
Okay. You don't have, okay.
I do have. I have it.
Okay, okay. If you have my number, just please knock me in the WhatsApp. I want to say something there after the session.
Sure, sure.
Thank you very much, Jazakallah. And Dr. Muhammad is there, Dr. Muhammad Galal. We will request him also. So, what is the most likely diagnosis? Jacob's arthropathy, rheumatoid arthritis, and gout, psoriatic arthritis, Jacob's sarcoid arthropathy. 40-year-old woman is seen outpatient rheumatology clinic. She was diagnosed with SLE 5 years ago when she has presented fatigue, anemia, rash, and she also has a PMH of hypertension, gout, and psoriasis. Okay. So many things. Gout, psoriasis, and she's having the SLE, hypertension. She had noticed that joints in her hands were becoming deformed. However, she was able to complete day-to-day tasks without any functional impairment and denied pain in the affected joints. So there is something, deformity, joint deformity, and there is no pain. On examination, she had symmetrical marked reducible ulnar subluxation and deviation at the metacarpophalangeal joints. Okay. So there is ulnar deviation, and subluxation at the uh, metacarpophalangeal joints. Okay. Ulnar subluxation. X-rays of her hands showed no erosions. What is the most likely diagnosis?
Jacob's, Dr. Tariq. It's
Okay,
symmetrical,
Jacobs.
yeah, painless, non-erosive SLE.
Okay, so this is Jacobs arthropathy. Okay, thank you very much. So very nice. Thank you very much, Dr. Saad. And the key here is the absence of pain, which is more than likely to be present in options B and E. So in rheumatoid arthritis and sarcoid arthropathy, we will be having the pain. Otherwise, features can be same, and the X-ray findings can be same. Additionally, gout usually affects the first metatarsal head, and sarcoid arthropathy is very rare, hence Jacob's arthropathy, which is non-erosive and associated with the SLE, is the correct answer. So they are saying gout usually affects the first metatarsal head, and obviously in gout there can be pain. Sometimes there is no pain if there is not too much
And
swelling.
erosions. And the
Yeah, erosions
erosions.
are there. Erosions are there, and whereas in Jacob's arthropathy there is no erosion. In gout, there is punched out ulcers, erosions are there, overhanging edges are there. So gout usually affects the first metatarsal head, and sarcoid arthropathy is very rare, hence Jacobs is a no, which is non-erosive, and associated with SLE is the correct answer. Okay. Okay. So this SLE, general features, fatigue, fever, mouth ulcers, and lymphadenopathy. There are some 11, criteria for SLE. And I think I have the notes I will share in the group about related to 11 criteria on SLE. And you can see, and I think 7 out of 11 or 6 or 7, I forget the exact number. 6 out of 11, if positive, this will be considered as SLE. Features of SLE include, and it is more common in the Afro-Caribbean and more common in the women. Fatigue, fever, mouth ulcers, lymphadenopathy. Skin, malar rash, we know, discoid rash, scaly erythematous, well demarcated rash in sun-exposed areas. So there is malar rash, butterfly rash, space nasal label pores, and discoid rash. This is due to the photosensitivity. Lesions may progress to become pigmented and hyperkeratotic before becoming atrophic. Photosensitivity is there, and Raynaud's phenomena. Obviously, there will be involvement of the something like a vasculitis, you can say. Livedo reticularis. We have seen in PAN also polyarteritis nodosa, there is livedo reticularis. In cholesterol embolization, when you do some procedure like PCI or coronary angiography, the patient can, and you use the contrast, patient can develop the cholesterol embolization and patient can develop livedo reticularis. So livedo reticularis we can see in cholesterol embolization, in SLE, and also in PAN we can see this. And PAN is also one of the systemic vasculitis. Non-scarring alopecia you will see in case of SLE, whereas in case of what is this called?
DLE.
Yes,
Why is it
DLE,
DLE?
discoid lupus erythematosus. In
That is
discoid
scarring.
lupus erythematosus, there will be scarring alopecia. Scarring alopecia. So here it is non-scarring. And musculoskeletal arthralgia and non-erosive arthritis. So if you see the arthritis here, it is non-erosive arthritis, and patient will be having arthralgia. And this is maybe part of the, you can say, Jacob's arthropathy. And cardiovascular pericarditis is the most common cardiac manifestation. Myocarditis also can occur. Respiratory pleurisy, fibrosing alveolitis, proteinuria, and renal glomerulonephritis. And we know the 6 types of lupus nephritis we did in nephrology. And diffuse proliferative is the most common and the most severe form, which is type 4 lupus nephritis. Neuropsychiatric features, anxiety, depression, psychosis, and seizures can develop in a patient with SLE. Given the most likely diagnosis, what is the most appropriate next step? Arthroscopy, MRI scan, physiotherapy, ultrasound, X-ray. So given the most likely diagnosis, what is the most appropriate next step? Arthroscopy, MRI scan, physiotherapy, ultrasound, or X-ray. On examination, the affected shoulder is painful and restricted with both active and passive movement. So this is the frozen shoulder or adhesive capsulitis, I think. And external rotation is almost fairly limited. This is again a feature of adhesive capsulitis. Pain is elicited when applying direct pressure to the coracoid process. Again, this is simply a case of, and type 2 diabetes, more common in diabetes mellitus patients. So this is adhesive capsulitis. Given the idea, what is the most important next step? Next step, we will go with the physiotherapy. This is a clinical diagnosis, and we can go with the physiotherapy in such cases. Adhesive capsulitis is clinical diagnosis and does not need imaging or arthroscopy to confirm the diagnosis. Diagnosis is most likely to be adhesive capsulitis, and this is evidenced by the reduction movement, associated pain, and external rotation being more affected. The background diabetes mellitus is also a risk factor. And adhesive capsulitis is generally a clinical diagnosis, and so imaging or investigation not required. Physiotherapy is therefore the correct answer and the mainstay of treatment. It should be, so they are asking what is the most important next step. So it should be initiated as early as possible. Arthroscopy, this may be considered much further down the line as a therapeutic option. The previous measures have failed to control the symptoms. So this will be, it will be the, maybe down the line, it will take more time. And if you have done the pain physiotherapy you have done and no result in 1 2 years because it's a condition that takes 1 to 2 years to revert, then we can think of doing the arthroscopy. MRI, this may be useful if the diagnosis were not as clear cut and other pathologies needed to be ruled out. So, if not a very clear cut scenario like our scenario, then we can think of doing the MRI to rule out other causes. Ultrasound may be considered before MRI if the diagnosis is uncertain and differentials need to be ruled out. However, in a case such as this, the clinical picture is sufficient to make the diagnosis. And X-ray may be considered to exclude dislocations and fractures. However, the history bar pictures very strong research to adhesive capsulitis, so imaging is not needed. Physiotherapy should be initiated. Okay. So down the line, only this is the most, plausible answer which we have given. Is a common cause of shoulder pain, and it is most common in middle-aged females. So mostly females are affected. The etiology of frozen shoulder is not fully understood. Associations, diabetes, up to 20% diabetics may have an episode of frozen shoulder in their lifetime. Features typically develop over days, and there is external rotation is affected more than the internal rotation or abduction. Both active passive movement is affected. Patients typically have a painful freezing phase, an adhesive phase, and a recovery phase. So there will be painful freezing phase and the adhesive phase, and finally the recovery phase. Bilateral in up to 20% of the patients, will mostly you will see it as unilateral case. The episode typically lasts between 6 months and 2 years. So 6 months to 2 years is the duration of this episode. Okay, the diagnosis is usually clinical, although imaging may be required for atypical or persistent symptoms. So in a 6 month period or 1 year period, no improvement. So then we can go with the, imaging. No single intervention has been shown to improve outcome in the long term. Treatment options include NSAIDs, physiotherapy, steroids, and intraarticular corticosteroids. So you have 4 things here in the treatment: NSAIDs, physiotherapy, oral corticosteroids, and intraarticular corticosteroids. So these are the treatments that we can do. So this is looking like a discoid lupus or something related to that. But the most likely discoid lupus, alopecia areata, and psoriasis, and trichotillomania, which is a psychiatric problem, and patients are removing their hair. Squamous cell carcinoma. So squamous is out, trichotillomania is not like this picture. Psoriasis also not like that. So we are alopecia areata also. I think there will be some, this is non-scarring. This is non-scarring. Discal lupus is the scarring one. 35-year-old woman presents with alopecia. For the past few months, she has noticed some scaly patches on her scalp. Once healed, they normally leave a scar, and no hair seems to grow back. A scalp has the following appearance. So this is simply a case of discoid lupus. Scarring alopecia. Remember that alopecia may be divided into scarring and non-scarring. And scarring means destruction of the hair follicles. Non-scarring means preservation of the hair follicles. Scarring alopecia, trauma, burns, radiotherapy, lichen planus, discoid lupus, like our patient, tinea capitis if untreated. Non-scarring, male pattern baldness, drugs, toxic drug, carbamazepine. By the way, radiotherapy will give you a scarring and chemotherapy will give you a non-scarring. Okay. Chemotherapy will be non-scarring. Radiotherapy, both these are for the cancer's treatment, but one is giving you scarring and the other no. Carbimazole, heparin, oral contraceptive pill, colchicine, these are the non-scarring ones. Nutritional iron and zinc deficiency and autoimmune alopecia areata. Alopecia areata. Telogen effluvium, hair loss following stressful period, for example, surgery. And trichotillomania is, due to some disease, due to some psychotic illness, patient will remove the hair from the scalp or maybe other parts of the body. agree.
CC does. CC. Yes, it can be reversible. Discitis from the urinary tract infection. Colon cancer will not give meds to the spine. Usually meds to the liver. Most likely. Ankylosing this one. 5A, remember 5A.